Hello, everyone. My name is Hayley McCorkle, and thank you for tuning in to the virtual Nancy and Bill Norton Education Series, our 30th anniversary edition. Now that you all have watched the nausea and vomiting sessions, we have gathered each of our presenters here today to have an open panel discussion. So with us, we have presenter Dr. Braden Kuo, who is an assistant professor of medicine and medical director of the Center of Neurointestinal Health at the GI unit in Mass General Hospital at Harvard Medical School in Boston. And in his presentation, you all learn more about nausea and vomiting, and he provided his unique insights on nausea and vomiting and as well as current treatment options. We also have with us today Dr. Thangam Venkatesan. So she's recently just transitioned to The Ohio State University. And in her presentation, you all learned about the history of cichlid vomiting syndrome, how it is diagnosed, and common characteristics, and how cannabis impacts cannabinoid hypermesis syndrome, which is also referred to as CHS, and much more. We also have with us today two patient advocates, Trisha Bundy and James O'Reilly. During Trisha's presentation, she shared with us how living with gastroparesis impacts her life from day to day, tips that have helped her manage her gastroparesis, and words of encouragement for others who live with a similar condition. And last but certainly not least, and during James' presentation, he shared with us how living with CVS has impacted his life for many years, tips that have really helped him manage his CVS, and a really touching moment during his presentation about what motivates him through some of those challenging times, and as well as some encouraging words for those who might be living with similar conditions as well. So I just want to say thank you to all of you all for joining us today.
It's a
Thank you,
pleasure.
Alice.
Thank you.
Thank you.
Absolutely.
So I personally really enjoyed watching each of your presentations on conditions that are considered to be rare GI conditions, but actually impact a significant number of people in the United States. So it's very exciting to really have you all here with us today to dig a little bit deeper into each of these topics and answer some of the questions from our viewers. Starting with you, Dr. Kuo, one of the questions from our viewers specifically talks about gastroparesis. So, what is the prevalence of gastroparesis in the United States?
Well, I think that it's an interesting question because people define gastroparesis as this condition of measured delay in gastric emptying with the symptoms of nausea, vomiting, and also frequently abdominal pain. According to the NIH website, out of 100,000 people, about 10 men and about 40 women in 100,000 carry the diagnosis of gastroparesis. But I would say that the interesting thing is, as we are learning more about gastroparesis, a lot of patients present with the abdominal pain, nausea, and vomiting. And the measurement of gastroparesis to define delayed gastric emptying sometimes shifts, and that there are probably a lot of people out there who may have delayed gastric emptying one day and not delayed another day that could also meet this criteria. So this whole understanding of gastroparesis and another entity called functional dyspepsia, abdominal pain, nausea, vomiting is evolving.
Yeah, I'm so glad that you brought those things in. And definitely, like you said, research is evolving. And as the research evolves, what are some of the most commonly known causes of gastroparesis?
Well, I think in general for gastroparesis, the traditional thinking is dividing it into one large category of causes from diabetes, where people with potentially long-standing diabetes is a complication of diabetes because diabetes can affect the neurons, the nerve endings in the entire body from the eyes to the hands and feet. It can also affect the nerve endings in the gut and leading to dysfunction called the dysfunction of gastroparesis. And that is one etiology. Another large category is called idiopathic gastroparesis. Now, that, frankly, is just a wastebasket of all the other different causes, of which there are a myriad. People can have a terrible food poisoning or some sort of viral incident or some other event that somehow shocks the system, maybe through inflammation, rawness of the tissue, and that rawness or irritation may heal, but that in itself causes major changes to the nerve endings in the gut and how they move and sense things. And those changes persist despite the initial insult potentially disappearing.
Absolutely. And so you talked a little bit about gastroparesis as well in some of your presentation, but how common is it to be placed maybe on a feeding tube for those who might be living with gastroparesis?
Well, it's less common. It's not ideal because it's considered more of a situation of a last resort. Many of us try to do our best to try to do anything medically, cognitive, behavioral wise, or otherwise to prevent it. But sometimes in cases where you cannot, you have an absolutely flaccid stomach that doesn't empty and you need to get nutrition in the person and you want to avoid nutrition by vein, which has its own complications, you may be forced to place a feeding tube. Generally, I would recommend a feeding tube that feeds directly into the small intestine, bypassing the stomach, and avoid using any sort of opening to the stomach to vent and decompress the stomach. Because even though you may get temporary relief from that, in the long run, the adage I like to use is if you don't use it, you lose it. And so by venting the stomach, while you may get temporary relief, that stomach getting decompressed doesn't have exercise and stretching out, which is something that you need to develop if you're ever going to think about having feeding in the stomach ever again by mouth.
Absolutely. Trisha, I see you nodding, and we're kind of going to transition over to your story, but still, this question is for you, Dr. Kuo. One thing that personally I found shocking while listening to Trisha's story is she lived what was a normal lifestyle to a lot of us, and she really enjoyed spending time with her family. She was a teacher. She loved outdoor activities until one day she wasn't feeling well and she woke up having symptoms, and this is when her life was like completely changed, and she had a new life story where now she was faced with these challenges that she would endure with being diagnosed with gastroparesis. So how common is Trisha's story in terms of gastroparesis?
Well, I think that gastroparesis can come in many flavors. And I really, my heart goes out to you after all that you've been through with your particular story. I will admit your story is probably on the more severe side of just the consequences of what you've been through. It can be as mild where people get the symptoms, and usually when you go to the doctor, they say, oh, well, in a couple of weeks, your problems will get better, or in a month or two will get better. But in some cases, with gastroparesis, 6 months, 1 year goes by and you're not better. But I know in your particular situation, I mean, it's just this terrible downhill course where not only is your upper gut affected, but your lower gut affected. And it's a cataclysmic change in terms of going from something that works that you take for granted to totally not working from top side and bottom side. And I think that's less common, but very devastating, showing you sort of like, number one, how all the different areas are connected, top side and bottom side. Number two, when one thing goes awry and the inflammation can cause its effect in the GI tract, that inflammation can go away. And some people respond, but other people just go on a very terrible downhill that you're trying to stabilize. And we are doing our best to try to understand the path of physiology, how this develops. And there's been some evidence in taking biopsy samples and tissue samples of gastroparesis. There is this sort of inflammatory reaction that occurs that can persist, unfortunately, in a certain group of people to sort of lead to the demise of neurons, nerve endings in the gut to lead to this worsening conditions, and other people that somehow may recover. But it's not as common, but I certainly see my fair share of these challenging situations because it's frustrating. You hope that it goes away in 3 months, 6 months, 1 year, and it just doesn't go away. It only gets worse and worse and worse until you meet a group of experts that can at least do their best to stabilize your condition.
Yeah. And I really like how you touched on that gastroparesis comes in many different forms and it's not specific to one patient. However, this is common and is a common condition. And Trisha, I just want to say thank you for sharing your story and your journey of what it was like. And if you haven't had a chance to listen to Trisha's story, please do. But for a second, we're just going to shift gears here and kind of start talking about cichlid vomiting syndrome, which was another portion of our nausea vomiting session. And so, Dr. Venkatesan, this question kind of goes to you. What are some of the causes of cichlid vomiting syndrome, and what is it?
Yeah, so that's a very good question. And first, as to what it is a disorder. It's a chronic disorder of brain-gut interaction, and essentially, in the past they used to call it functional GI disorders. So the center for vomiting is in the brain, and really the network for nausea is in the brain as well. And so it is this condition where patients can, like James, really described, you have repetitive or recurrent episodes of nausea and vomiting. They just come out of the blue. And then over time, they can actually get a lot worse. There does seem to be some relationship with migraine headaches, though I would not call it a quote migraine. It is very common, and we know that now. It also affects adults. And as far as the cause, though the cause is not clear, certainly we have some clues. So, for most disorders, there's usually a genetic component and then environmental factors. So when we talk about, say, the genetic component, there is something in our body called the endocannabinoid system, and also something called cannabinoid receptors. So, I did a study with some collaborators in Germany, and where they found that there were problems with certain receptors, cannabinoid receptors, which are present in the brain, very important for nausea and vomiting, and they were associated with an increased risk of CVS. Now, these are only clues. It doesn't mean it's a cause. So certainly there seems to be some genetic predisposition to develop CVS. And then on top of that, there could be environmental challenges. So be it stress, and often people will say, not all the time, but either negative or positive stress. So is there something wrong, or something dysfunctional in the way patients say respond to stress? Is there something wrong with the endocannabinoid system, or something called the hypothalamic pituitary axis, where if we are confronted with a stressful situation, we all produce, cortisol, and we're in the fight and flight mode. But after the tiger's, kind of the stress is gone, we all need to come back to homeostasis. And so maybe for CVS patients or other patients, that stress response doesn't come back to normal. And so maybe they're in this heightened state of responsivity. So I think we have some clues. So certainly there are genetic factors. Stress is a very important component, we think, in this. It's not completely clear, but obviously we're doing a lot of, we're doing studies, and hopefully the NIH will, give us more funding to really do the important work to clearly understand what it is that causes these people to vomit. Obviously I don't want to get into that, but marijuana. So marijuana is another thing. Does it, is it a separate disorder, or is it a part of CVS? Because, the marijuana that's actually used these days is very, very potent. It's very powerful. What was used in the 1990s was, if there was what is called 5% THC, which gives you the high, now it's 15%. And now, in fact, with hydroponics and other things, people can make marijuana with 85% THC. It's enough to knock a horse down. And so I think it's a totally different beast we're talking about, and how that affects, in somebody who's potentially genetically predisposed. It's very possible that this is a trigger, and it can make CVS worse. Or I wouldn't necessarily say it's a cause, but I would say that it could potentially trigger or make things worse. And so I think there is a lot of misinformation there, about what actually constitutes cannabinoid hyperemesis and so on. And it's very controversial. But I think, again, we have some clues, and hopefully, in the next 5 or 10 years, we really hope to increase our knowledge by doing studies and understanding this a little better.
Yeah, definitely trying to understand more. So, what are the causes? And like you said, funding is very crucial, and being able to understand some of these things. And this next question actually goes into a little bit of what you were just touching on, but it can go to either you, Dr. Kuo, or Dr. Vankinson, whoever wants to answer. Cichlid vomiting syndrome and CHS are very, very similar conditions. So can either one of you explain the differences between the two?
So I can
Why
take
don't you
that.
go
I'm fine.
first?
I
You go
did a
first.
huge
We'll see.
systematic review. And so, as far as CHS and CVS, so the symptoms are the same. And if you might actually get different answers if you talk to different people. Whether CHS is actually a separate entity itself, I think is in question to me personally, and based on all the literature and the evidence that's out there, I think CHS is probably a subset of CVS. A lot of what should I say, noise was made about this hot water bathing pattern where people with CHS are supposed to get into hot water or hot baths. And in fact, they will, they can even shower like 20 times a day when they have an episode. And then everybody said, oh my God, this is, what we call pathognomonic, or this is typical for CHS. And if you have the hot water bathing pattern, you have CHS. But that's been disproved. We did a study, and almost 40 to 50% of patients with cyclic vomiting syndrome who don't use cannabis also have the same bathing behavior. So it's not like it is specific, and I think the problem with most of the studies is people describe CHS as anything they wanted it to be. And so there was no uniformity in the way they diagnose it. And only in 2016 did the Rome Foundation actually come up with criteria for CHS, and we don't know enough about it. So, I personally, I do think that it's probably a subset. I do think that heavy cannabis use is a problem. The symptoms tend to be the same. CHS is a little more common in younger males, well, simply because younger males use a lot more cannabis. So I think we could talk about it for an entire day, but that's my short answer.
I think
Let Brad comment
completely
on.
agree with what you're saying. I think the struggle for patients, honestly, is that just because you take a puff of marijuana does not mean that you have cannabinoid hyperemesis, and that oftentimes the medical community, I think, is a little bit pejorative in the past about viewing the use of marijuana and its implications for cannabinoid hyperemesis or cyclic vomiting syndrome. But the reality is that the prevalence use of marijuana is extremely common, and medical doctors have to kind of adjust their viewpoints that this is not something that is illicit. This is, in many cases, this is something that people are going to oftentimes for medicinal purposes. And so it's very important to point out the definition now is that if you have tried a period of being marijuana free and you still have persistent symptoms, then you probably do not meet the criteria for cannabinoid hyperemesis. And I think that the challenge has always been people are too quick to just call them CHS, stop marijuana, and then that causes all sorts of patient-provider conflict because they're like, they don't like to be told that and dismissed. So I think those are important things that have to be considered.
And there's a stigma. Unfortunately, they stigmatize these patients and they actually withhold therapy. So I don't withhold therapy even if there's, quote, suspected CHS. So I would treat them just like you treat a CVS patient, whether it's tricyclic antidepressants, abortive therapy, and obviously tell them to try and cut it down. I mean, there is a difference between heavy use and occasional use. So daily and near daily use is certainly a problem. Cannabis concentrates is a problem. And so those are things that need to be addressed. But, being dismissive, like Brad Kuo said, and actually withholding therapy, which could help them, because I've had umpteen number of patients who have been told they have CHS, they've stopped it for a long time and their episodes continue. So it's really important to, keep that in mind.
Yeah. And you two really thank you for mentioning all of those things and transitioning into actually what our next questions are for both Trisha and James. where some of the viewers here, they had some questions about maybe what are questions that you would have liked your healthcare provider to ask you in the beginning of your journey, starting with you, Trisha, of living with gastroparesis?
I actually think the providers that I came across asked a lot of the right questions. I think that some of them were dismissive of the answers or not taking in the impact that it was having on my life as much as they needed to. For whatever reason. I mean, a lot of mine to begin with, asking about day-to-day life. I was a teacher, had young kids, and so the thing came back that it was always, oh, you must be stressed, or the weight was the issue. I was very obese, and so they were like, well, you can't be having these problems. You're not having trouble eating if you're maintaining that weight or you have that weight. Even though I was losing all along, I was still overweight. So it was just kind of pushed on the back burner, some of it.
And I would bring out that it is not uncommon to have obesity with gastroparesis, and that sort of, and the explanation I give is that obesity itself is an inflammatory response, a mild inflammatory response that can also work deleteriously against the nerve endings in the gut. So, but I know there's a lot of prejudice that's experienced, as you were telling us that can happen from providers regarding that.
But asking just more of, I guess, would have been the impact it was having on the life itself, and realizing that the stress that was coming from the illness and not being able to carry out the duties as I used to be able to was stressful. But that was a result of being sick and not being able to do what I needed to.
Absolutely. Doctor-patient communication is definitely important. James, what are some questions that you maybe wish that your healthcare provider would ask you at the beginning of your journey of living with CVS?
Sure. So I started getting it around when I was 28, and it was 3 or 4 times a year the first year, and then 7 or 8 times the next year. And it was 23 years ago that I was first kind of introduced to cyclic vomiting syndrome as an adult of 28. And I was in great shape. I was playing ice hockey 2 or 3 times a week. I mean, I was going to the gym. I was running or riding bikes, maybe 40, 50, 60 miles a week. And so I was always doing something, and my job is in construction and pool service, so I'm always active. I don't know, though, back then, 23 years ago, that the knowledge of cyclic vomiting syndrome was as well known then as it is now. I make it a point of every doctor I go see, whether it's just for a checkup or a this or that, whatever it is, hey, have you ever heard of cyclic vomiting syndrome? And now I'm getting 75% have heard something of it, and 25% haven't. Now, I also find that the younger doctors are finding it that they've heard something more about it than the older doctors. I've also dealt with the prejudice that was described by both doctors here that, oh, well, if you smoke marijuana, then that's what the problem is. Well, that's fine. But when I was a child in Ireland, I can promise you that my folks didn't know where to even get marijuana, never mind about to have it or see it. And so that wasn't an issue. As an adult, I stopped smoking. And so I stopped for a while, and I still had episodes. And so I've kind of ruled that out. I do find that for me personally, is that it's either stopped episodes cold in its track at times, or it's at least slowed them down enough where I have enough energy and wherewithal to get to the hospital, to get my medications, and to do that. But the overall questions at the beginning were, well, do you drink? It wasn't so much about CHS, because CHS wasn't as prevalent. It was probably just the beginning of that 23 years ago. So I don't know that the questions could have been asked any differently than what is he eating? Did he do anything? Has anybody else in the family been sick? Has he been out of the country? All of those kind of questions. And
I do think one thing that
sorry.
CVS patients it also experiences prejudice is when they go to the emergency room and they get acute care. You're suffering with a lot of pain and narcotics, are frequently helpful, and you may need more than the standard amount of medications to achieve relief, whether it's with benzodiazepines or narcotics, and you get labeled as a drug-seeking behavior problem patient, and
Yep.
that's a tough label, particularly with electronic medical records to deal with. And so I know that that's a prejudice that exists that has to be clearly addressed in the medical record of what diagnosis you have, and also have an acute care plan in the record of the emergency room or the hospital you're going to, so that when somebody opens it up, Mr. Jones, oh, you're here for your 10th time in the emergency room, you can see very clearly, oh, this is not somebody that's requiring 10 milligrams of IV Dilaudid just for the sake of he wants to feel comfortable. You have cyclic vomiting. There's a clear plan of this is what we're going to do to treat your problem. And I think that makes a big difference for a lot of patients and how they're received.
I can tell you from my own personal experience that that has absolutely made the world of difference for me. I went and saw Dr. Fleischer, and then I went to the Mayo Clinic a couple of years ago, and they both confirmed what I had just based on all the tests. And I came up with a plan. Now, granted, I go to the hospital 20, 30 times a year. So it's James, come on in. Nice to see you again. How's your son? Blah, blah, blah. I mean, I'm half the family already. But at the same point, I had a plan made up. And every time I get to a hospital, they look it up, or they can call my hospital and say, yes, he's been here. This is what we give him. I also have a port in my chest, so that brings a little bit more seriousness to the party. But I have been escorted out of a couple of ERs because I was a drug seeker and by security under Ativan, and I should not have been driving. And so there's a real problem there as well. I'm glad to see that more and more doctors, as I ask the question, have you ever heard of? That they're able to say, yes, I have. I've never met anybody before, but yes, I've heard of it. And that's a tremendous step forward, I think, just in anybody trying to get some treatment.
And there's been a big increase with the gastroparesis community as well, because when I was first diagnosed, going online, just trying to find something out about it, and there was nothing available, talking to other medical professionals, and they're like, I don't know what you're talking about, or, oh, that's just like a stomach ache, you'll be fine. But now that you can find a lot more information available, and yeah, when I go to the ER or when I go to see new doctors, they're more familiar with the what gastroparesis is and the impact it can have on some lives. So that's been very encouraging.
I agree. I think that there's significantly more literature talking about the severity of the conditions you're going along with, and thankfully, due to UpToDate and Dr. Google and PubMed, people can actually look this stuff up.
Yeah.
And what you all are really touching on is very important, especially for all patients, to really be an advocate for themselves in these spaces and when they have their appointments. And like both of you, asking the doctor, have you heard of? And making them aware also of these conditions, because maybe that might stimulate them to go research on their own, and now they are informed. So the patient doctor communication is very crucial, and being an advocate for yourself in those spaces are just as important. So thank you both for not only bringing in those stories, but also touching on those crucial points.
If I may add to your point you just
Absolutely.
made, and that was that over the course of the last 20 years, and probably in the last 10 years, I've been told by 2 or 3 different doctors that if it wasn't for you and your CVS, I wouldn't have been able to diagnose 2 or 3 other people.
Mm-hmm.
And 2 of them were teenage girls. And I think I found out from the nurses that it brought a lot of comfort, not only the parents, but the patients themselves, that, wow, I can put a label on whatever it is that's affecting me.
Absolutely.
So that alone just makes it worth that. Unfortunately, I get sick and I get in the office, but or in the hospital, but I can help other people just by spreading the word. And so that's why I make it a point to ask.
Yes.
Yeah, that's terrific. And I think, like James said, just having your symptoms validated instead of, being dismissed and say, oh, there's something like, you're crazy, or there's something, nobody can figure out. And it's just like any other disorder. I tell people, it's like diabetes or hypertension. Nobody questions you, right? If you say you're diabetic. or whatever else. And so you have to treat it as such.
Yeah.
I think that with the literature involving, Trisha's case, I think one of the things in gastroparesis was people thought that it's just a disorder of stuff moving poorly in the stomach and didn't fully recognize that pain is prevalent in practically 90% of gastroparetic patients. And the old adage was, if you have pain, you can't have gastroparesis. But the literature that the consortium and other people are reporting, legitimizing that it's a full complex of different symptoms, including pain, the impact it has upon quality of life, and then suggesting the different ways to approach those different types of symptoms, not only motility, but also the pain aspects are really important in offering options and legitimizing what you're going through.
Yeah. And so just a few other questions here, and one goes to you, Dr. Venkatesan. So what might be some other vomiting disorders that our viewers should probably be made aware of while we're still talking about the subject?
So in terms of vomiting, you have cyclic or recurrent vomiting, and typically patients go back to baseline. And then you have something called chronic vomiting. So chronic vomiting is more a disorder where you're kind of, vomiting almost daily or near daily. And perhaps you might see that in conditions like gastroparesis and so on. And then you have the recurrent episode of nausea and vomiting, which is more typical of, cyclic vomiting syndrome. Having said that, and James can attest to this because he said it himself, right? He had 3 to 4 episodes a year, and then he had 7 to 8, and then he had multiple. So I always tell people, you got to go back and take a good history, because if you don't treat it and then they just kind of, really uncontrolled, the episodes become longer and longer, and the periods of wellness become shorter and shorter. And after a while, like nobody knows what's going on, and you're sick all the time, and so on. So I think one is the pattern of vomiting, really needs to be differentiated. Certainly, there are other things called what we would call organic pathology. Doesn't mean so functional is, it's very hard, right, to understand about these centers in the brain. Even though you have like functional MRI studies, it's not used in clinical practice. And so there are some other vomiting disorders where there's organic pathology that you have to rule out. That's why you would maybe do an endoscopy, make sure the stomach is not twisting and turning suddenly. But that's organic pathology. And if that's happening, you actually fix it with surgery or other means. There are some rare disorders that can, cause vomiting, sometimes something called neuromyelitis optica, actually. And I've diagnosed a patient like that who has recurrent cyclic vomiting, and they actually had blurring of vision, and they have something totally different, like an autoimmune condition. There's something called hepatic porphyria, where actually patients with hepatic porphyria and CVS have a huge overlap of symptoms. And, we actually completed a study. It doesn't seem to be the case, but so there's a lot of disorders of nausea and vomiting out there, which are not necessarily GI. And it's up to the physician to kind of figure that out. You don't have to do $1 million, and you shouldn't do $1 million investigation and then put the patient through unnecessary procedures. But I think a good history and just some basic tests will figure out. The other thing I forgot to mention is that sometimes with autonomic dysfunction, like Brad was describing earlier, like POTS, people just feel sick all the time, and they have nausea and they have vomiting here and there. And it's actually, it's because of the underlying POTS. And if you treat the POTS and the autonomic dysfunction, it's likely that the GI symptoms will also improve.
Yeah.
So there's a lot.
You're thinking of all the terrible ones. I was just thinking of 2 very benign ones that people present with, like rumination syndrome.
Or rumination too, yes.
Just purely by history. That's people that eat a meal and then they regurgitate it up. It's not projectile vomiting, and then they re-swallow it. And they may not even think that's abnormal, but there are people around them find that very abnormal. And that's very treatable.
Yeah, absolutely. So I agree, like rumination, one of the reasons why I didn't bring it up is typically it's not a vomiting disorder because you're not actually vomiting projectile. And so it's almost like a learned behavior. Nobody really knows, and different people classify it, differently. And so it's, like you said, it's just a propulsion of gastric contents that comes up, and you're able to control it and stuff. So it is very different. And again, I think a careful history will give you that. And so I think that's key.
Yeah, yeah. And so, Dr. Kuo, going to you, and you kind of started touching on this, but what should someone consider maybe when to go see a healthcare provider if they are experiencing nausea and or vomiting?
Well, I think that everybody in their life experiences nausea and vomiting at one point or another. I mean, but the question is, how often is it? Is it persistent? And does it affect your quality of life and your ability to function? Does it affect how you're able to eat your meal? Are you able to maintain nutrition? Are you having a lot of pain afterwards? And so it moves to going from the grocery store or the drugstore aisle saying, oh, for nausea and vomiting, I'll take a little antacid. That doesn't work. The problem doesn't go away in a couple of weeks. Then you're talking to your primary care doctor. The primary care doctor may try acid suppression medications, which may not work, or may, and if it persists for longer than that, then they'll want to do some testing to further evaluate ruling out life-threatening causes, ulcers, blockage, and such. And that usually is the point that it gets referred to a gastroenterologist to do the rule out evaluation, as well as then beginning to treat the ongoing symptoms that are persisting longer than a couple of weeks.
Absolutely. And so now that we're kind of just to wrap things up here and kind of hear again from you, Trisha, and you, James, maybe how can you explain how your appointments with your healthcare provider have evolved over the years and maybe provide a little bit of words of encouragement for our viewers today? I'll start with you, James.
Okay, so how's it progressed over the years? Great question. So because we didn't know what it was for the first 3 or 4 years, that was tough. I remember what really precipitated me finding out about it was my ex-wife was told by the 8th visit one year that, oh, he vomits, people vomit. And that was just not acceptable to her at 4 in the morning. And she went back to her office and somehow found cyclic vomiting syndrome and read it and saw that that was the steps, and what I was going through was probably 95% of the symptoms. So I was more proactive at that point than getting the right treatment plan to my hospital from Dr. Fleischer, who I had met with. And also the Mayo Clinic gave some hints. And so we put together a package on that. It really came to the point where I've had some of my own personal doctors say to me, listen, you know more than I do about this. What do you think we need to do? And I would actually go to them and say, well, maybe we need to up my amitriptyline a little bit, or, should I do this or should I do that? And it was kind of a collaborative effort. And I've been blessed with doctors that certainly care about what happens. And maybe because I see them so often with so many trips to the hospital, but I'm very lucky. And I've been on both ends of that, of course, as I described earlier. I just know how tough it is for people to get the right treatment. So for me, I've been a little bit more of a leader. I have a psychology degree, but I also did a lot of studying of drugs and human behavior, and I have a little bit of understanding of receptors and all of the things that go along with that. And so I've been educating myself a little bit along the way, and then just trying to bounce those thoughts or ideas off of my doctors, and come up hopefully with a reasonable way of trying to deal with what I'm dealing with.
What about for you, Trisha? What are some things that you're experiencing today, and maybe what are some words encouragement, excuse me, that you might have for the patient community?
Well, I'll start off with the words of encouragement, actually, that there really are some very caring and compassionate doctors that will go above and beyond to help research and connect with you. So just be patient. They're out there. And I'm sure there's a lot more than you realize, but it's just getting in with the right ones that are for you. To begin with, like I said, there was the going through the ruling out, the colonoscopies and all that to make sure that there was nothing noted, and then just kind of hands being thrown up. I don't know what else to do. And then just kind of being lost. After my first hospitalization, I was able to get teamed up with a great fellow actually, who took interest in the case. And so he was able to help me get a little bit more understanding. He was the one who came up with the looking at that diagnosis. And when he moved, I was kind of lost a little while, worried about the new doctor that was coming in, but I'm still with him. I've been with him since 2015. And it's just been a lot of trust, a lot of listening to each other, him taking in what I'm going through, me listening to what he has on the medical side, and just the honesty there. Him coming out and telling me, yeah, I don't really know what else we can do. We can try this. If that doesn't work, we'll try this. But hey, you let me know along the way what's working. And I don't know, just that openness with each other has been very helpful. Like James was saying, kind of doing that own research. Support groups are very helpful in the community. If you can find the right ones. I know they can be frowned upon by some as well, but listening to some of the other experiences and what they've tried, I was able to take back to my doctor and ask him, you know, what do you think this medication would be one that would be worth trying? And he could tell me the reasons why it might be worth trying or the reasons why he didn't like that decision. And so we're able to talk about it. So that's been, that was very helpful as well.
Thank you.
I think it's amazing that I agree with you that, you know, you get to a certain point with extremely challenging cases, and I certainly, both of us see our share, that we have a certain process of things that we do, which is probably straightforward for mild to moderate cases. But when you get to severe cases, there's no plan, there's no direct playbook. And it's really that partnership between the patient being the advocate. I far more enjoy working with a patient that is willing to take responsibility for some elements of their care and throw back ideas and suggestions and have it be a dialogue of trial and error or communication rather than the patient coming to me and say, I don't know what to do. Like, what are you going to do for me now? What are you going to do for me now? Like, well, I've done a lot of different things. You tell me a lot of things don't work. So like, let's work together on this. And that's much more enjoyable and rewarding as an active process rather than purely passive process of them expecting me to come up with all the answers when reality is there's no clear playbook when you get to a certain level.
Right, which is something I've really respected with my doctor, is because he'll come out and tell me that he doesn't know what the next step would be, but he's not going to give up on me. He would keep trying, we'll keep looking. There's new stuff coming out in research. So he's just knowing that he's there and that he's willing to admit, hey, there's more things that we have to learn about this. I don't know everything, but we're going to get through this together. That's been
helpful. Yeah. What about for you, Dr. Venkatesan? Do you have any words of encouragement as well for the patient community?
Yeah, I mean, I think, you know, again, like James said, you know, CVS has been, you know, it's sort of really a journey we're seeing. And, you know, I do think I'm very hopeful. There are some new drugs in the pipeline and there are new things that are coming up. And so I'm very hopeful that this landscape will actually change completely, you know, hopefully in the next 5 to 10 years maybe, and you know, everything that we've published will become obsolete and we'll have new things you know, happening in CVS. And I really think it's important to have that relationship with your physician, and there should be trust. Because once you trust that person, and at times for very severe cases, I think it's very important to trust, and it has to go both ways, that, you know, you're willing to, you know, give and take a little bit, try out new things. But yes, I think there are exciting things. I really do think that, you know, collaboration and participation and really kind of working together as a team, I think there's a lot that can be achieved. And even with the current medications, in fact, we have you know, I'm going to present that at the upcoming DDW, the outcomes are very good, you know, and I think we can make it a lot better.
Dr. Kuo, do you have any finishing words?
Oh, I don't know why I get tasked with this, but I think that, you know, with any patient experience, it's a journey, and that when you get to the more severe cases, it's going to be a partnership in that journey with the healthcare providers and a bit of communication and give and take to try to get through this together. It's not something where the doctor should be telling you 100% this is what I'm going to do or else, but the same lines, the patient also has to be their own advocate to bring up ideas and support from all the different resources that may exist.
Absolutely. Team effort and throughout the whole process is key, and just making sure that communication is definitely there. So I just want to say thank you to all of our presenters here today for answering the questions that our viewers had and just going into depth about a lot more detail in this from this nausea and vomiting session. And thank you to all of our viewers who are watching today. If you would like to view other presentations from the NES 30th Anniversary Edition, please visit our IFFGD YouTube channel. And if you have any questions regarding the presentations, please contact our staff at iffgd@iffgd.org. And so thank you everyone who has tuned in.